This video lecture is an introduction to diagnosis and the Diagnostic and Statistical Manual of Mental Disorders, known as the DSM. We're going to start with the theory of the medical model upon which the DSM is founded. The DSM and the medical model boils down psychopathology to two main criteria. The first is distress, the second is impairment in functioning. Severity is measured by frequency, duration, and intensity of symptoms. Frequency, meaning how often those symptoms occurred. Duration, the length of those symptoms. And intensity, how severe they were. So, for example, with panic attacks, we want to know how often they occur, that's frequency, how long they last, that's duration, and how bad or intense they get, and that's intensity. Let's explore distress in a bit more detail so we understand what it means when we talk about distress and then impairment in functioning. Distress is very important to consider when making a diagnosis of a mental disorder, mostly because distress tends to be the reason why people seek counseling services. So, what constitutes psychological suffering? What is distress? I think most of us understand this as a sense of internal, inner anguish and upset about events in a person's life, or even internal stimuli that are going on. It's the sense of not wanting things to be a certain way. So it may well be, for example, a sense of sadness at a breakup or a loss. It may well be a sense of suffering based on hearing voices, if that makes sense. It's this sense of wanting things to be different and undergoing some kind of internal pain related to that. Suffering is not always present, though, in an abnormal presentation. In fact, you can have someone who is hurting others, but does not experience a lot of suffering themselves. You see this in antisocial personality disorder, for example, whereby a person will violate the rights of others, causing them a lot of pain, but themselves they don't experience a lot of distress or anguish about causing others pain. So suffering is not always present in an abnormal presentation. In addition, suffering or distress is not always maladaptive or abnormal. Sometimes it is very normal. For example, a person who has lost a loved one, such as a grieving widower, would be participating in what we would consider normal or typical responses to that loss by grieving, by experiencing internal suffering based on that loss. And so the sense of distress that person feels is not necessarily a bad thing, not necessarily abnormal. It's a fairly typical response. In fact, we might even say that someone who does not experience distress, that they are experiencing a fairly abnormal response because they should be grieving. You'll often see this with clients who don't seem affected by a loss. We wonder about how it really is affecting them and why they're unable to experience that grief fully. That is different than an occasion whereby someone encounters an abnormal experience of distress from something like formication, which is known as delusional parasitosis. It occurs in psychosis states whereby a person feels, for example, spiders, ants, bugs crawling in their skin that aren't really there, but they experience that on their skin. And formication is quite an unpleasant experience and can cause distress in people, and we would consider that a fairly unusual experience and a marker of psychopathology because it's not a normal response to environmental events. So, in other words, there are different kinds of responses that indicate whether or not the distress is typical, normal, or more abnormal, more psychopathological. In addition, suffering is an indicator of psychopathology, but may or may not be sufficient, meaning there may be other symptoms needed beyond distress to diagnose psychopathology. Impairment in functioning is one of those that we look at in addition to distress or suffering in terms of whether or not we diagnose someone with a mental disorder according to the DSM. Impairment in functioning is about whether a person's behavior interferes with their ability to function in the community. There are a variety of ways in which a person functions on a day-to-day basis in a healthy manner. Some of those things have to do with the activities of daily living, or ADLs, you might have heard. Things like getting up in the morning, taking care of one's hygiene, eating breakfast, getting dressed, being able to live in a clean environment, being able to get to various appointments or work commitments, being able to come home and eat dinner and wash themselves, and all of those kinds of things, handle money, things that we do on a day-to-day basis that help us to be able to just live our lives in a fairly typical fashion and function independently. Those are the activities of daily living. Even things like bowel movements are important to monitor, because if you have someone who is struggling with a neurocognitive disorder like dementia, for example, or Alzheimer's, and they're unable to go to the bathroom by themselves, that's a major marker of psychopathology because of their impairment in functioning. They're unable to care for their daily needs. So there's the activities of daily living. There's also this ability to function in the community. We look at how engaged the person is. If a person is unable to be in social circles, unable to go out and do what they need to do, and to also contribute to society, in addition to look after their individual well-being, we are concerned about that. For example, someone with agoraphobia may feel like they cannot leave their house and do not leave their house, and may be house-stricken for months at a time. And that is not considered to be a normal or healthy behavior because of the impairment in social functioning that engenders. The person has less social contact, they are not able to contribute to community well-being. Maybe they feel distress about wanting to leave the house, but even if they don't feel distress, we would still consider that to be impairment in functioning. As a contrast to this, and I like this example that I'm about to share with you next, because it shows you that even among conditions that we would consider to be psychopathological, a person can actually use those conditions to function healthily, meaning they don't experience a dramatic impairment in functioning. So this is the contrast. Someone with hypomania may well be able to harness some of that additional energy that they have, that sense of self-confidence of being able to achieve anything, and be a successful salesman, perhaps a car salesman, or maybe even a real estate agent. If they're able to do that, we would consider them to be actually fairly successful by social standards, because especially in Western society, if you're able to be successful in what you are doing, then perhaps it's not the most abnormal behavior to have. In fact, it may well be a strength of yours rather than an impairment. And so impairment in functioning is important because we want to know whether or not a person is able to function on a day-to-day basis to do what they need to do to maintain work, to maintain a healthy relationship with others in their communities, and to also contribute to their community. All of that is important to determining whether or not a person has a mental disorder or not. I'll add, just before I get into the statistical versus clinical significance, that in terms of impairment in functioning, it's also very important to be aware that a lot of diagnoses in the DSM require multiple settings that symptoms occur in order for the diagnosis to be made. For example, if you are someone who is being evaluated for ADHD, you have to display symptoms not only at school, but also at home and in the community. I think you need at least 2 settings. Same way around, you can't just display symptoms of ADHD at home but not in other settings. And so we do pay attention to how a person behaves in various settings and what that means in terms of how severe their symptoms are, and whether their symptoms are consistent across settings, or whether it's more to do with who they're around, for example, like if there's a particular social environment that causes them to act more hyperactive, say, than others, or more inattentive than others. Okay, moving on. So we're talking now about statistical versus clinical significance. This is very important to understand when we are looking at how diagnoses are made in the DSM. You may recall from your assessment class that when we look at research studies, when we look at using assessments, typically we diagnose based on what's called T-scores, or usually a standard deviation of 2 above or below the mean. So a T-score of 70 or a T-score of 30. The reason that we do that is because we look for that magic 5% of people who are above, only 5% of people score a certain way above or below the norm group or the sample group. And so we want people to be in that 5% range in order to determine what's called statistical significance. This is a norm-referenced version of assessment whereby we are comparing a person's scores with population norms. Clinical significance is different. This is criterion referenced, meaning you have a panel of experts who get together and decide on the criteria by which a person meets or does not meet the cutoffs for something like a diagnosis. And we do not use norms for that criteria. So in other words, the DSM, to give you an example, was created by a panel of experts who got together and decided what symptoms constitute, say, depression among all of, and all of the other diagnoses, and decided on how many symptoms you needed and what kinds of symptoms you needed to qualify for that diagnosis. That's criterion referenced because it's based on this checklist, this criterion by which you must have, say, 5 of 9 of these symptoms to qualify. In addition to that, we are not looking at norm groups. And that's important to remember, because if you actually read through the DSM, it's apparent that the percentages are quite different among different diagnostic categories in terms of incidence, or the frequency by which a person is diagnosed with a mental disorder in the population. Like, for example, bipolar disorder has an incidence of 1% in the general population, meaning about 1% of people are diagnosed with bipolar disorder, whereas if you look at ADHD in children and adolescents, it's about 8%, meaning about 8 out of 100 people are diagnosed with ADHD in the general population. So you can see there that our 5% rule doesn't really apply, and part of the reason why we're not using statistical significance there is because there's this sense that regardless of how frequently a person meets these criteria, there needs to be some set standard for what constitutes a mental disorder, and some people are going to meet that, perhaps much fewer than 5% in some cases. But there needs to be some kind of a standard that experts agree on that meets the diagnostic threshold for those diagnoses. So the DSM uses clinical significance rather than statistical significance to determine diagnoses. To meet diagnostic criteria, a certain number of symptoms have to be met. I had mentioned the 5 out of 9 or what have you. It's important to remember that because typically we tend to focus our attention on some symptoms which are usually major markers of one of those disorders. For example, hallucinations with schizophrenia, or in bipolar disorder it might be, for example, grandiose or expansive mood. These symptoms are important, but there is no single symptom that is going to meet full criteria for a disorder, meaning even with schizophrenia, if you just have hallucinations and none of the other criteria for schizophrenia, you can't be fully diagnosed with that disorder. You have to meet all of the conditions, the criteria for that disorder, not just the one symptom. It's almost as if that major marker is a kind of, if when there's smoke there's fire analogy. It's kind of like a prompt for you to find out more information, to do a fuller assessment to make sure that the person meets the criteria for that disorder or not. So it gives you a clue that you may want to assess for a disorder further, but a single symptom does not meet full criteria for a disorder. We're going to talk now about the clinical disorders in DSM-5. Clinical disorders are essentially the billable disorders, the ones that you work with clients to remediate based on the presenting problems and their treatment plan. So let's start out with how we report and code these. So first of all, when you have a clinical disorder that a person is experiencing, you want to be reporting this, and you want to be reporting all of these. Even if it is something that a person is recovering from, or what's called in remission from, meaning they have experienced, let's say, substance abuse and have been in remission for 10 years, we still want to report that as part of their diagnostic profile, because it does give you a sense of what the person has struggled with in the past and where they're at currently in their recovery. And in addition, it also alerts the clinician to be aware of the possibility of relapse. So we begin listing diagnoses with the principal diagnosis or reason for visit. This is listed first. We want to first indicate what diagnosis is the one that the client is coming in and receiving treatment for. This is really important to get right for a few reasons. Number one, and most importantly, if you diagnose a primary, if you give someone a primary diagnosis or a principal diagnosis, that should be the diagnosis that guides your treatment planning, meaning you should fit your theory and interventions to that first diagnosis and make sure that that first diagnosis is the one that you're really treating the most. So you want to make sure that when you give someone a primary diagnosis that you know that is going to be the focus of treatment. Second, establishing a principal diagnosis or reason for a visit is also important not only for the treatment plan, as I have mentioned, but also for diagnosis and billable purposes for insurance companies. So if you do not have a principal diagnosis or reason for visit that is very strong, like if you have, for example, an adjustment disorder or a not or unspecified, for example, disorder, you should know that that's may well elicit fewer visits from the insurance company than a more severe disorder. So you don't necessarily want to do what's called upcoding, which is to give someone a more severe disorder in order to receive more sessions. But you do need to be attentive to what disorder am I really treating here, and how many sessions do I need to do that, and if I don't think the insurance company is going to give me enough sessions to do that, that's a discussion to be had with the client. I also think it's very important to talk to you about primary diagnosis or principal diagnosis in terms of personality disorders and intellectual disability. Students will get confused with this because they will see a personality disorder in a client, and you'll see this in some of the cases you're about to address. And you'll list that first thinking, well, this is really the reason they're coming to therapy. This is what I need to work with them on. Personality disorders are not considered to be principal diagnoses for the reason that they are considered somewhat stable and thus chronic, meaning you cannot ever fully remediate a personality disorder because by their very definition and nature, a personality disorder is enduring. It is part of a person's personality. You cannot help to alleviate that fully. What you can do is help a person manage symptoms associated with their personality disorder. So, for example, a client who has borderline personality disorder may well have episodes of depression or episodes of, say, psychosis, brief psychosis, or even substance abuse based on their personality disorder, that it causes them to have these symptoms that emerge. And you may well want to address those symptoms as your primary diagnosis. So I'll address the depression, or I'll address the substance abuse, for example. And that would be perfectly acceptable and fine, but you do not want to be using borderline personality as your primary diagnosis. You will not get reimbursed by insurance companies for that, and it's just not good practice because you cannot really ever fully remediate a personality disorder. While there are treatments, there are counseling approaches for borderline personality disorder, such as dialectical behavior therapy. Usually those kinds of approaches help a person to manage symptoms. So they use things like mindfulness for dissociation. They use things like distress tolerance for emotional dysregulation issues. So in other words, you're helping a person to cope with symptoms rather than resolve a personality disorder. Intellectual disability functions somewhat similarly. There is somewhat of a consistent profile of a person's IQ scores across their lifespan right up until they get to older adulthood when there might actually be a deterioration based on things like Alzheimer's disease. But right up until then, usually a person's IQ score is fairly consistent. And so it is unlikely that you're going to remediate an intellectual disability. You cannot make a person have a higher IQ score or be smarter or take better care of their functioning, of their day-to-day functioning. Uh, I'm sorry, let me paraphrase that again. You cannot remediate a person's IQ score, but what you can do, similarly to personality disorders, is help a person with managing their day-to-day functioning better. So taking better care of their hygiene, or making sure that they're able to pay their bills, that kind of stuff. It can be very important to work on with that person. Again, those are considered to be the symptoms that you're helping the person with, but the core issue is never fully resolved. The person does not remediate or resolve their intellectual disability. I hope that makes sense. So, personality disorders, intellectual disability should not be a primary or principal diagnosis. If you have other hypotheses, so let's say you have 2 or 3 diagnoses, one of which is your principal diagnosis, and you also have some other possibilities that you're really not sure about. These are just things you're thinking in your mind. This is something that could be going on for the client, but I just don't know either way, and I don't feel confident about it, but I would want to rule it out. You could list these as what are called rule-outs. A rule-out is something whereby you need more information to just make sure that a person doesn't have this problem. A rule-out is not officially used as a diagnosis. It's almost like a just area for further assessment. In addition to rule-out, there's a further classification, which is called provisional. Provisional is very useful, especially when you're seeing a client for the first time, because often you do not have the complete picture. You're not completely sure of what the diagnosis is because you may be missing information, or the client doesn't meet full criteria. They haven't met the time length, for example, for depression, or they haven't met all of the symptoms for depression. But you're pretty sure that they have major depressive disorder. So you would list provisional, meaning you are waiting for them to basically evidence all the full criteria, and then they would have that diagnosis formally. So provisional means you are pretty certain that a person has this diagnosis, but you don't have all of the information you need yet. Whereas a rule out is saying I don't have information that much at all. It's almost more of a gut feeling of I need to rule this out as a possibility. The reason that provisional diagnoses are important is because most insurance companies require that you provide a provisional DSM-5 diagnosis within the first session, the very first session you meet with a client. So you want to be asking in the first session some structured questions. You don't want to spend the entire session asking structured questions. You want to ask some to guide your diagnosis of the client, your provisional diagnosis. You should have finalized the primary diagnosis by the 4th or 5th session. Part of the reason for that is that you will need to develop a treatment plan within about 4 to 5 sessions, and remember, your treatment plan should be informed by your diagnosis. So you need to have a diagnosis, a primary diagnosis, in order to have a treatment plan, and all of that should occur right around the 4th or the 5th session. So we've talked about clinical disorders in the DSM-5. We're now going to talk about medical conditions, which are also listed as part of the diagnostic profile of a person. You list medical conditions after mental disorders using what are called ICD codes, which will be officially used in the United States on October the 1st, 2015. So if you are watching this video and currently in practice before October 1st, 2015, you will be using ICD-9 codes. If you are watching this lecture and you are preparing to or working with clients currently and using ICD-10, then you will need to also understand those codes, which are 2 separate coding structures, and I'll show you them in a moment. The complete medical code list for ICD-10 is included, and you will see that in one of the future courses that you're going to be reading up for. So I have that code list for you, and I recommend reading it when we get to medical conditions, because at least skimming through and seeing what's in there can be very useful. And there's thousands of diagnoses, so you literally just want to scroll through and get a general sense of what's in there. Okay, your DSM experience in this course. This is how you'll be using DSM. For the case studies in Ariadne's thread, which you'll be reading, you will use knowledge from readings and lectures. So you will be reading the DSM in various chunks of chapters. And you'll also be participating in lectures. And in addition, when you get to your cases in Ariadne's thread, I expect you to be independently researching different disorders, meaning you won't just be using the DSM based on the chapters that you've read, although I have aligned most of your chapters with the cases you'll be reading about. I also want you to be skimming through the DSM and doing your own independent research for other possible diagnoses and making some decisions based on your research. This is important for you, although it is time intensive, because it gives you practice with scouring through the DSM, and when you are in clinical practice, that's a lot of what you do when you make a diagnosis. You aren't going to be basically a living cyclopedia of all of the DSM diagnoses. That those aren't going to exist in your brain. Instead, you're going to be looking through the DSM and finding diagnoses that you think fit the client and reading about them. So it's important for you to start that practice now. Let's go through some example DSM-5 coding, and after this I'm also going to show you the difference between DSM-4 and DSM-5 coding for those who are still in their sequence by which they haven't reached October 1st and their agencies are still using DSM-4. Okay, example DSM-5 coding. You have 296.22F32.1, major depressive disorder, single episode, moderate. This means someone has clinical depression. It's the first time that they've had it, single episode, and it's moderate in severity. This is a provisional diagnosis and their reason for visit. Provisional, meaning we don't have enough information yet. Perhaps they haven't met full criteria in terms of time or symptoms. And reason for visit, in terms of this is why the person is seeking therapy. The coding, the numbers, we'll get to in a minute. It will make more sense when I show you the chart on the next slide. Okay, next diagnosis, second diagnosis. We have post-traumatic stress disorder with dissociative symptoms. This is the second diagnosis, meaning in addition to clinical depression or major depressive disorder, the person also has PTSD, and they have a specifier of with dissociative symptoms. Dissociative symptoms is when a person either is very disconnected from their emotions, or they experience flashbacks, or they have periods by which they stare off into space, kind of zoned for long periods of time, and have a lack of memory for those moments when they were zoning. So specifiers are often used with diagnoses to just give some clarity to what kinds of flavor of the diagnosis they have. There is a difference between someone who has PTSD with and without dissociative symptoms. This person has it with dissociative symptoms. Note that this is a secondary diagnosis, meaning the focus of treatment here is going to be major depressive disorder, although the PTSD may well interact and perhaps be caused by the major depressive disorder. So we want to be aware of it, although our treatment planning is going to focus more on the major depressive disorder than the PTSD. We have a rule out next of nightmare disorder with associated non-sleep disorder, persistent moderate. This means that a person is having nightmares, or maybe we want to rule it out, with an associated non-sleep disorder, most likely probably PTSD, although depression can also cause sleep problems, that is persistent, it's ongoing, it's not episodic, meaning it doesn't happen every once in a while, it happens almost every night, and it's moderate, meaning the nightmares are pretty bad but not as bad as they could be. Now, the reason this is a rule out, maybe we need more information on whether the nightmares meet that full criteria for the nightmare disorder. Maybe we also have a rule out here because it's not clear if the sleep problems are better attributed to depression or to PTSD. So we would need more information there to make that a formal diagnosis, but certainly something you do want to be looking at, because nightmares or sleep issues, regardless of where they occur, can really impact a person and can cause impairment in things like depression or PTSD. They can worsen those diagnoses. We next have a medical diagnosis called hypertension essential, and this is per or by medical records, meaning that a person has in their medical record hypertension that is essential, and that's a specific term for the kind of hypertension a person can experience. I'll add as an aside that it's important to add biomedical records as a specifier to a medical diagnosis, because you should not be making medical diagnoses. Those should be made by a physician. You should be mentioning them if there is a history of that diagnosis that was diagnosed by a physician, and you would get that information by medical records. You know, a release of information to the doctor to determine the exact state or form of the diagnosis that they have medically. You don't just accept the client's self-report. Most of the time you should be reaching out to the physician with an ROI to get a sense of what exactly they are experiencing. Hypertension, of course, means high blood pressure. If you would like more examples of how to diagnose using the DSM-5 coding, there is a wonderful handout called DSM-5 case examples that I've made available to you that you could read about to see some other examples of what it looks like. Okay, I'm going to briefly go through this table. It's an important table for you to understand, particularly as you are exposed to DSM-4 and DSM-5. There are some of you who are watching this who do not need to know this, and you can skip through this part of the video. But for those who are either currently using or will be using DSM-4 and then transitioning to 5, this is important for you to know about. So DSM-4 had a very different coding structure than DSM-5. It had a 5-axis system, and you need to know and understand those 5 axes because those are quite different than DSM-5, which has a single-axis coding system. There are 2 examples I'm going to walk through with you. The first is an example from a child and adolescent client. The second is an example from an adult client. Let's look at the child and adolescent client first. This person has an Axis 1 disorder, and Axis 1 means clinical disorders, of Asperger's disorder, with an ICD-9 code of 315.39. That's the ICD-9 code for Asperger disorder. It has a slash of autism spectrum disorder because in DSM-5 there is no more Asperger's. That's been replaced with just a broad autism spectrum disorder diagnosis. So they have as their primary diagnosis Asperger's disorder. Axis 2, which is personality and intellectual disability. This was, remember, there's no 5 axes in the DSM-5, but in DSM-4, Axis 2 is basically non-clinical issues such as personality disorders and intellectual disability that can't be really treated or remediated, as I mentioned. It says deferred here, meaning we do not know whether a person has a personality disorder or intellectual disability. More assessment needs to be made. The term deferred is pretty much excised from DSM-5 because we don't have a 5-axial system, and therefore if someone doesn't have a personality disorder or an intellectual disability, we don't even write about that because we just have a single-axis coding structure. Axis 3, generalized non-convulsive epilepsy. So a person is experiencing seizures that are non-convulsive, meaning they do not cause a person to convulse. They may be more like absent seizures, whereby a person would just stare into space for long periods of time. And they are generalized, meaning they happen in a variety of contexts. The ICD-9 code is 345, and that is a medical coding for generalized non-convulsive epilepsy. Axis 4. Axis 4 has to do with what's known as the impact of social environment, of occupation, of legal history, of primary support group, basically psychosocial issues that impact the clinical diagnosis. Here we have academic or educational problem. So this person having some issues at school. Perhaps they have an IEP or an individualized education plan. Perhaps they have a 504 plan. Perhaps they are in a what's called a isolated classroom setting. We don't know the specifics, but what we do know is that they have an academic or an educational problem, and that is impacting the Asperger's disorder, or perhaps is impacted by the Asperger's disorder. They have an ICD-9 code of V623. As an aside, V codes were replaced with Z codes in the ICD-10, as we'll see in a minute. And Axis 5, this is Global Assessment of Functioning, a scale from 0 to 100 that rates basically a person's level of functioning, also known as a person's disability level, really, with the 0 being very, very low functioning or high disability level, and 100 being very high functioning or low disability level. The person has a score of 51 here. So that gives you a sense for their DSM-4 rating scale. If you want more information about the GAF scale, I will happily provide that to you. Just email me and I can give that to you. DSM-5. So the same case, now we're looking at DSM-5 coding for this. So we have single axial coding. So we have Asperger's disorder / autism spectrum disorder, semicolon. Generalized non-convulsive epilepsy, semicolon. Academic educational problem. You can see here how this is just more easily defined. It just has a better flow to it. And the ICD-10 codes for those are F84.0, that's for the autism spectrum disorder, G40.A, that's for the generalized non-convulsive epilepsy, and Z55.9, that's for the academic or educational problem known as the psychosocial stressor, or the Z code. So that's the child and adolescent example. Let's look at an adult example. For the following case, we have an Axis 1, or a clinical diagnosis of dysthymia, also known as in the DSM-5 as persistent depressive disorder. This has an ICD-9 code of 300.4. Dysthymia means low-level depression that exists for about 2 years. Axis 2, personality and intellectual disability. We have borderline personality disorder. 301.83 is the code. This is not, remember, the primary diagnosis, but it is important to be aware of when planning treatment, and it appears this person is experiencing low levels of depression that are chronic, ongoing, probably related to their borderline personality disorder. Axis 3, obesity. This has an ICD-9 code of 278. Axis 4, we have several things listed here. Non-adherence to medical treatment, problem related to lifestyle, unavailability of healthcare facilities. All of those have separate V codes. Then we have a global assessment of functioning score of 43. That's lower than 51, meaning this person is more impaired than the child or adolescent. Okay, so now looking at the DSM-5 single axis coding. It's basically the same, except it reads in a better flow. Dysthymia or persistent depressive disorder, semicolon. Borderline personality disorder, semicolon. Obesity, non-adherence to medical treatment, problems related to lifestyle, unavailability of healthcare facilities. All of those have ICD-10 codes, so dysthymia or persistent depressive disorder has F34.1, borderline personality disorder has F60.3, obesity has E66.9, and so on and so forth. So you see here how it's kind of comparable how the diagnosis is made between DSM-4 and 5, but the main difference is how it's laid out, and there is a 5-axis coding structure for DSM-4 and just a single axis coding structure for DSM-5. I hope that makes sense. Okay, we're on our final slide. We're about to go through some tips, really important tips when you are making diagnoses, and this will help you. You may well be feeling overwhelmed when reading the DSM, and that's okay. That's part of learning this new language. Remember that diagnosis is not an exact science. As with assessment, there are a lot of gray areas when you're making a diagnosis. Because of that, clinicians can disagree. We can have a different interpretation of the clinical picture and the diagnosis between clinicians. The important thing is to be in the ballpark. And this is what I mean by being in the ballpark. You want to determine differential diagnosis, so basically deciding between diagnoses that are fairly comparable with similar symptom presentations. For example, it is okay to determine an adjustment disorder with depressed mood versus an unspecified depressive disorder. If you're looking at either of those are in the same ballpark. So it's okay to go one way or the other on that, because a person with an adjustment disorder of depressed mood essentially is having depressed mood related to a stressor, which may be job loss or loss of a relationship, etc., etc. Or unspecified depressive disorder means a person is experiencing depressive symptoms but not with any identifiable stressor. So basically you're saying there the difference is, in one case there's an identifiable stressor, in another case there isn't. The consistency between them is that there are depressive symptoms that don't meet the full criteria for major depressive disorder, otherwise that would be diagnosed. That is in the ballpark. It is not okay to be deciding between adjustment disorder with depressed mood versus schizophrenia. Those are two very different diagnoses. Adjustment disorder with depressed mood is essentially about, again, a stressor that is causing a person to feel depressed or have a depressed mood, whereas schizophrenia is a very dysfunctional impairment in a person's reality testing, in their disorganization of thought, in their ability to take care of their day-to-day hygiene, and they also experience hallucinations and delusions. So all of those things are fairly significant and severe with schizophrenia, and adjustment disorder with depressed mood would be considered a much milder diagnosis, and really is not related to psychosis. It's more related to low mood related to a stressor. So those are two very different diagnoses, and I would not consider those to be in the ballpark because they're just so different. So I hope that makes sense to you, that when you're looking at diagnoses, we may well find there's variation among your cohort, your group, your class, and that's okay. Some degree of variation is okay, so long as the variety of diagnoses are in the ballpark of each other. But if you come up with a diagnosis that is very different than the clinical picture, and other students have quite a different picture of that diagnosis, then you're probably outside of the realm of possibility, and it's probably incorrect. But there is a lot of room for latitude there and leeway based on whether you are in the ballpark or not. So I don't want you to get too uptight about getting the exact precise diagnosis, as so long as you're thinking along the right lines and you've identified the correct symptoms. You will learn this process as we go along. So we have just completed the introduction to diagnosis and the DSM.